Thank you.
That's fantastic. Really, really exciting work. And I think it's so important to be getting the views of people using these systems. So Professor Mike Barnes now, Professor of Bioinformatics and Director of the Centre of Translational Bioinformatics at Queen Mary, University of London, and co-PI of AI Multiply. Thank you.
So today I'm going to try and give you a quick sort of glimpse at what we're doing in AI Multiply with polypharmacy. And I think this applies to everyone. And I'm going to skip through some quite detailed slides, but hopefully that actually gives you an idea of what polypharmacy, what working with polypharmacy involves. So polypharmacy, as I think we've already sort of seen, involves considering a whole range of factors to review medication and to give patients a medication that works for them, that deals with their symptoms, and that minimizes use of medication. I think that's really key. So we're interested in looking at pharmacy data, defining long-term prescriptions, and then looking at how those burdens of pharmacy, maybe the work of the pharmacy, it applies to patients. And then I'm going to give you a very quick example where we've been looking at chronic kidney disease as a model of polypharmacy. So we're working, like many here, with CPRD. We're working with a cut of 2.7 million patients that have 2 or more multiple long-term conditions. And when you look at the pharmacy data there, you can see millions of prescriptions for a range of drugs, a lot of which will be familiar to you, like statins, aspirin, and so on. But when you take this data, you actually have to start processing this data. And our data engineer, Raphael, who's at the back there, he's been working through a structured pipeline for analyzing and structuring polypharmacy so that we can extract long-term prescriptions throughout our data set, and also structuring them using the British National Formulary hierarchy. So there's a lot of challenges in dealing with polypharmacy. So as Bruce highlighted, we don't really know when a lot of these happen. We don't know. We know when a prescription is issued, but we don't know when the patient took the drug, or if indeed they took the drug at all. There's a lot of uncertainty. There's a lot of big data, and there's a lot of data that we don't have access to, particularly secondary care data. So there's a lot of very boring detail using tools like Drug Prepper that allows us to characterize and structure data, and a lot of the data is structured already. That helps, but there's still a lot of work to do, so I can skip through that. And then we had a lot of discussion about how do we actually define a long-term prescription. Long-term prescriptions are really important because they tell you not just the number of prescriptions the patient's had, but how long they've been on that drug. A length of time on a drug might have a sort of cumulative effect on the body and on the organs that are being treated with that drug. And Bruce Guthrie did some work on this almost 10 years ago, where they actually came up with 84 days as a good sort of gap to define a long-term prescription. So if you don't have a drug for 84 days, that breaks a long-term prescription. And we thought, right, well, let's try testing that. So we're interested in dealing with event data, and we've developed a tool that actually allows us to automatically identify groups of events with different windows. So we looked at an 84-day window, and we looked at a whole range of other windows with that tool. And the package developed by Alicia and my team, the Bursted Dynamics package, which we've used across events in healthcare records. So we've used it also for looking at the burstiness of healthcare data. But in this case, we've used it for prescriptions, and you can access the package on GitHub if you want to do this kind of work. So what it looks like is this. So if you look at different gaps between long-term prescriptions, if you at the top here, we've got 120 days, and at the bottom, we've got 30 days. And if you vary that with 84, second from the top, you can see that you get different numbers of long-term prescriptions. So a patient with the same patient with different gaps would have maybe 4 long-term prescriptions or 1 at the top. And that's quite important for predicting the effect of continuous dosing on a condition. And we then applied that to all medicines in CPRD, and this shows that different categories of medicines like cardiovascular, medicines for the eye, medicines for rheumatology, they have quite different thresholds. So there is some argument that you could vary thresholds, but also there's an argument that you could just stick with 84. So we did stick with 84. And I just want to show what polypharmacy looks like in action. So here we've got one patient that's taking 40 different drug classes, more than 40 drugs, and that's to treat more than 40 long-term conditions. And we're using our tools to sum up this type of pharmacy. So here's a sort of concept where you've got a patient over a number of years taking a number of drugs, and we can scan through that with window analysis, looking every year or every month, and we can score their amount of polypharmacy. So that gives scores that might increase or indeed might fluctuate and fall. So in reality, this is what the data looks like. So this is real data for one patient where we've defined polypharmacy. So I just wanted to talk about chronic kidney disease as one example where we're applying this. So chronic kidney disease is a really interesting condition that turns up with multimorbidity. Basically, many different conditions like hypertension, diabetes, cardiac conditions will lead to stress and strain on the kidneys. And recently, the NHS changed guidelines for defining chronic kidney disease, where they looked at changed it to filtration rate of kidneys. And this meant basically that many elderly people got automatically classified as mid-range chronic kidney disease. And this is quite important to tell the difference between somebody that's just got an aging kidney and somebody that's actually got pathology that's progressing in their kidney. So this is something that was raised to us by one of our clinicians and really makes it an important question for analysing CKD. And CKD is there's a whole range of conditions here that apply, and there's a bit of a vicious circle of pharmacy that affects kidney function. So we're trying to predict here progression from CKD3, which is middle range of kidney failure, towards CKD5, which is complete kidney failure. So we identified 5,000 patients that had kidney failure and 20,000 patients that had CKD3. And we looked at what just pharmacy was predicting that progression to kidney failure. So we used a gradient boosting model here, and we've ranked all the medicines that affected kidney failure. So we can see drugs that are used for renal transplant coming out quite near the top. But the drug at the top is an alpha blocker that's used for hypertension and heart failure and other diseases. This drug recently was tested in a large clinical trial and was shown to actually progress kidney disease, so that the trial arm with that drug was actually stopped. So it shows that by looking at GP data, we can actually find outcomes that large clinical trials are needed to find otherwise. So I will end there. I see I'm on red. And so basically we've shown that using CPRD data, we can start to make predictions about polypharmacy and show how that might affect patients and how we can better plan medicine for patients. Thank you.